in the library, the Atlas of Regional Anesthesia. And it's my great pleasure to welcome Dr. Brown today. He's going to be talking to us about local anesthetic toxicity.
Lindsay, thank you very much. First, thanks to all of you for inviting me. Very much like my experience with Mike Rosenthal, he's asleep, I think, in Vermont this morning, snowed in. And I'll tell you, Mike's the guy that actually asked me to come talk to the medical students tomorrow evening, give an upbeat thing about the specialty. And so I said, well, what can I talk about? All I do is take complaints now. It's hard to find some place that you're anchored clinically well enough. And I go back historically a little bit to local anesthetics. But let me tell you that Mike being snowed in or asleep has never prevented him from making a comment. I recall as a young board examiner, he was in auditing me one day. I was a junior examiner, there was a senior examiner, and Mike fell asleep over in the chair, and I could diagnose it because he was snoring. And yet, at the end, he was able to come up with a fairly articulate criticism of the exam, even while he was snoring. So I expect that Mike will rail us with stories tomorrow when he gets back. But he asked me to talk about some clinical subject with the medical students. So I thought, well, what do I know about that maybe I know a little bit more about than a lot of folks? And it's probably local anesthetic toxicity. So you might say, one of my old faculty once told me, don't make your name talking about complications. Well, I'm violating that right now. We're going to talk a little bit about complications. Before, I thought I'd share with you a little about the Cleveland Clinic. This is what it looks like when there's not snow on the ground, like area in the distance. Almost all of this is the Cleveland Clinic, downtown Cleveland here. And if we look at what the Anesthesia Institute is, it's really a big department. They just changed the names. And so we have 6 departments within our structure. We have what we call general anesthesiology, which is what most departments are anywhere else. What it doesn't have is cardiac. Cardiac lives in its own world, cardiothoracic anesthesia. We then have a pediatric anesthesia department, a regional practice, that's the dozen hospitals that ring the city. We have a pain management department, and then we have an outcomes research department that Dan Sessler runs. If you look at what the Department of General Anesthesiology does, they have about 65 ORs on the main campus. If we move over to where the cardiac people work, they do about 30 ORs each day there. We do about 25 pumps a day. And then, as is wont of every department in the country, we're spreading ourselves across the entire campus. And we do 40 sites in addition to those. 75 ORs out in the regional hospitals. And then our pain docs are in the Walker building, as you see in yellow. We have 5 ORs there with about 25 pain physicians spread across the city. And our ICU bed count right now is at about 160. And so that's, I was telling Alex that this is probably the best position I've ever held, and part of it is just the scale. You never have a dull day. We've got about 220 faculty and about 160 residents and fellows and 180 nurse anesthetists. So I've already dealt with somebody that I have asked to move on this morning. As I was East Coast time, I was able to get a little work done this morning, and always very interesting. Well, let's get in, see if I can get it to advance here. Okay. This was supposed to actually have been a fairly smooth transition to tell you it's not about ORs, it's not about buildings, it's actually about the people. And driving education right now is a big deal. We're all pressured. I've never seen more pressure on education than right now, on institutions, and less funding for education per unit of education that I've seen right now. One of the areas that I I stay tuned into. I'm a director for the ACGME, so I'm a bit of a clanging cymbal on the ACGME board, telling them perhaps we ought to move somewhere near the end of the 20th century with IT support for ACGME to get the residents, so that we're not asking residents to do scut work on entering data for their case logs. It's been a cymbal I've been clanging on for almost a decade. You can see how effective I've been. I think residents are still having to input all theirs, but it's really about the people. And for me, that's the biggest advantage I have at the clinic is I've got a lot of young trainees that you can imprint. Well, let's talk about what I'm here for today, and that's local anesthetic systemic toxicity. And I'd like to break this thing down really just into three areas. When does it happen? What's the pathophysiology? And then with lots of actually positive thoughts, what's the best treatment? This is an area that has really undergone a fair degree of change over the last few years. Well, let's go to when does it happen? Late Ben Covino, back almost at the time he was going through residency training, published this in his Pharmacology of Local Anesthetics, suggesting you can see that the convulsive dose is only a portion of what the cardiovascular depressive dose is. And that's fairly standard. Most folks aren't going to see too many episodes of cardiovascular collapse, even though very well written. It always generates a lot more interest if you talk about cardiovascular collapse than if you talk about a seizure. And Stanford actually has a fairly key role in local anesthetic systemic toxicity with an editorial that Albright wrote back in 1979. Well, let me just go back. You can see along the vertical axis, Ben had written milligram per kilogram dose. And I'd offer up to you many books relate a milligram per kilogram dose to prevention of local anesthetic systemic toxicity. And that's probably the most ill-advised direction in all of regional anesthesia. I mean, you can theoretically, there is some dose that if I just kept pouring it into you, you'd ultimately have a seizure. But 99% of every seizure or major event is produced because I've got the needle tip or the catheter inside a blood vessel, not because there's been uptake. The only uptake seizure I have ever had was actually one that I was cited in a PhD thesis for. And that's really turning the wheel. I had a young woman who'd been in this is when I was doing pain medicine, a flexion extension injury from a rear end of an automobile. She was an English PhD candidate at the University of Iowa. I was at Mayo at the time, and I typically did some trigger points on her because she was over the computer a lot. And on one day, they handed me, unknowingly to me, they handed me 0.5% bupivacaine rather than 0.25% bupivacaine. And about 15 minutes after I'd injected this, and this was without an IV, this was, well, she was flopping around like a fish out of water, as blue as some of the scrubs toward the back of the room. And I thought, well, this is really exciting. And we got her stabilized, and it was the best pain relief she'd ever had. And I honestly think it's probably because the central catecholamines go high with seizure, and we actually were cited, the whole team was cited in her PhD thesis because of the wonderful care we provided her. And I would offer up to the residents, one of the great unknowns in medicine is usually when we do our worst work, and if we actually recover well, patients think we've done our best work and that our administrations have been wonderful, and it's mainly because they know we care. It's not very complicated. Well, let's move to this. This happens to be actually a graph that was a study done back in the mid-70s, and epidural lidocaine injected, as you can see on the horizontal axis, there's weight. Vertical axis is mean plasma concentration. 400 milligrams epidural lidocaine, and then they just measured plasma concentrations. Best I can tell, that looks like an old shotgun blast rather than any line that I can draw through that. That the milligram per kilogram dosing regimen makes no difference if in 99% of the cases, the reason they have a seizure is we've got a needle or a catheter inside a blood vessel. So just keep that in mind as you talk about milligram per kilogram. I'm going to take you now to a study we did while I was at Mayo, which I still think probably is the largest look at systemic toxicity that has any sort of a prospectively entered data. It was entered into our computer database. We looked at it retrospectively. And what we looked at was seizure frequency across a large group of patients and then the accompanying cardiovascular changes. So let's look through this. 1,300 caudals. That must be the world's experience of late. I would guess other than pediatrics, there aren't 1,300 caudals done over a decade now in the U.S. We had 9 seizures out of that group. We weren't very good at that. You can see that was a 7 per 1,000. Brachial plexus block, and this went from axillary to interscaleing to supraclavicular, 15 seizures, a rate of 2 per 1,000. Now I want you to think about that because that number, 1 per 500, has been around since people were doing regional anesthesia, back from the 40s and 50s, right up through current. If you're going to do major peripheral nerve blocks, probably you can expect some sort of a systemic toxic reaction, about 1 in 500. Now, since many residents get to do somewhere around 40 cases during their residency, you may go entire careers without ever having seen it. Epidurals, 2 per almost 17,000, or 0.1 per 1,000. Dramatically lower than what any of us thought we would see. And these were not OB epidurals. These actually were epidurals that had enough dose given that you could have seized after the dose of local anesthetic was administered. Out of these seizures, 26 of them, I believe, every one of them occurred immediately at the time of injection. And when I say immediately, you might have put your needle back down on the tray and it might have happened 30 seconds, 60 seconds later, but these were all immediate seizures. Something that probably I'm the only person in the world that's paid any attention to this is let's talk about the hemodynamic changes that we found in the brachial plexus blocks. You see the pre-seizure number on the left, the post-seizure number on the right, and this is systolic blood pressure. With rare exception, each one of those actually had a little bit of an increase, probably as related to central catecholamines. Let's look at heart rate. Almost all were at the same heart rate to an increase with the seizure. If you look at what we did, and these were not prescribed, these were just what people did out of their common practice. You can see that 2/3 had a bag and mask, another third had endotracheal tube. Some of them got a relaxant. Almost everybody got pentothal. This was 85 to 92. A few got benzos. 1 got ephedrine. Nobody got epinephrine. 1 got bicarb. I don't know why they got bicarb. I have no idea why they got bicarb. And nobody got atropine. So again, out of those, and 15 of these were actually bupivacaine-induced seizures. So I offer up to you, it's not terrible. You're probably not going to kill tons of people if you're prepared. Now let me set the stage for you. In this setting, each one of these was administered in an induction room where there was somebody taking care of the patient in addition to me or somebody else doing the anesthetic. So we had people there, they were monitored, it was well lit, our drugs were there, we didn't have to run away to get drugs, and you need to have that context in this. But having a seizure in and of itself isn't life-ending, even though as you read some of the text you would believe it is life-ending. So let's get to the question, when does it happen? 99% of the time with injection. rarely with uptake of local anesthetic. You can do it. I've proven you can do it if you give it the wrong drug in and give enough. I don't know that I've ever seen a seizure from a lower extremity nerve block. I think I've done a fair number. I don't think I've ever seen. I've seen a fair number with brachials, seen a fair number with epidurals. I don't think I've ever seen one with lower extremity. I almost think you can't give enough on the lower extremity to cause a problem. So what does it look like? Here's probably the most important thing for the residents, because most of the residents are going to go through their training never having experienced a seizure. And the first time you see it, it's a little bit startling, off-putting. You wonder, could it really be happening as they become that fish out of water? The first thing they'll get, in my experience, is that far-off look. They're no longer home. They've got that far-off look. If you actually ask them later, they might actually hear a little bit like a seashell up to their ear. Have that kind of a noise. Needle may be in or out. The patient really is out of touch, and the seizure follows quite quickly. If you're doing a stellate ganglion block, I had a former fellow who's now teaching regional anesthesia. When he was getting a little cocky as a late in his fellowship, we were together in pain clinic. He was doing a stellate ganglion block on some guy with a Crips. And for some reason I could tell something wasn't quite right as he did the test dose of 1 milliliter here as we were giving 10. I said, stop, let's get the needle out. And just at that point, I think what it was, I must have seen a brush of blood. This was pre-fluoroscopy. And the guy flopped around. And, a 1/4 milliliter going through the vertebral right to the brain is enough to cause a seizure at that point. And so we had just barely whiffed a little in, and it was very short-lived. You really didn't have to do anything because it passed through, the lungs took the rest out. But you do develop a sense around folks of when they get that far off look. It's that 1,000-yard stare. And they're no longer home. And if there's nothing else the residents learn out of this, learn to be very sensitive to that 1,000-yard stare as you're doing regional anesthesia. Now, why does that happen? Why is it that we're also very good about aspiration? Well, I would suggest to you that there's often a little intravascular flap of some sort, whether it be intima or something. You put your needle in, you try to aspirate, nothing comes out, you got a little flap valve against it, and then you can inject the medication, and here we go. Fluoroscopy helps this in pain clinic, but it doesn't help it in the regional anesthesia world because we don't do this with that kind of imaging. Well, now I'm going to, just so you know, I'm standing on a soapbox, and I'm going to talk to you about the dumbest things I hear around people doing regional anesthesia. So we've given our 3 ml test dose. We've got the patient sedated, and you ask, now you may get a metallic taste, you may hear ringing in your ears, you may get tingly. And this is all at the time you're trying to watch their heart rate to see what happens with the test dose. Well, I'd offer up to you that 45 milligrams of lidocaine, I can put into any one of you here, and you like it right into your aorta, and you're likely not going to hear, see, smell, taste any of that stuff. I like to let the patient rest quietly and watch their heart rate rather than say, tell me if any of these terrible things are going to happen to you, and see then try to judge heart rate. But it is true that the progression is like this with cardiovascular depression at the top. Know also, I can guarantee you, you cannot have local anesthetic systemic toxicity from a spinal unless you do your spinals in a very unusual manner. There's just not enough drug there. I doubt you can do it intra-articularly. Subcutaneously you can. Where's that happening right now? Plastic surgeons' offices with the high doses they're using for some of the liposuction, things like that. Femsciatic, I have not seen it. Brachial plexus, epidural, caudal, intercostal, and interpleural is starting to be a little bit dated. So what's the pathophysiology? offer up to you seizure. That's what most of us are going to see. And then the plus minus cardiovascular depression and acidosis. Nobody really talks about this acidosis much, but I believe it's probably central to why we have problems. And I'll share with you in a few minutes a little more about that. One of the benefits are the lungs actually act like local anesthetic sponges as a local anesthetic comes through, and they can be overwhelmed with a big dose of local, but they actually are a bit of a sponge for us. If you look at where this all starts, it really is at the amygdala. Many of us in the old days used to hear about so-called Jacksonian March seizures that started somewhere and then progressed and generalized. It'd start out in an arm, start in a leg, something, and then generalize. That's functionally what we have here. And if you watch, some of these actually do have many of the elements of a Jacksonian seizure. It sits out there in that temporal lobe, and as the local anesthetic rises there, you'll start to see that far-off look, and then progressively a major motor seizure. Probably if I had to rank my most dramatic seizure, and I do have some experience in this, so you never want to trust anybody that's talking about something they don't have experience in. I'll guarantee you I've had a fair number of seizures through the years. Ben Covino was a visiting professor in Seattle when I was at Virginia Mason, talking about local anesthetic systemic toxicity. The next morning I'm working with one of the residents, and we're using 0.75% bupivacaine. You can tell it's been a while. And this young woman coming for a laparoscopy, and we did most of our laparoscopies under epidurals at that point, low volume of air, and but she seized just as big as anything. I mean, it was a full 30 ml, 0.75% bupivacaine, and Ben was standing over my shoulder when she seized. She did fine. We took care of her, and she went ahead and had things done after we kind of got everybody settled down. But they are dramatic. Seizures are dramatic. This one slide that comes out of Clarkson's work in anesthesiology in '85 probably contains the nuggets of understanding why bupivacaine can be such a problem. This is time-scaled along the horizontal axis of this image. And it was a basic science study looking at cardiac conduction and the so-called fast-in, slow-out concept of bupivacaine. Look at those heart rates at the bottom. So you got 60. We don't get too many of us slower than that unless we're really, really well beta blocked. Then you got 120. Not too many of us get to that lying around. And then you got maybe some babies that'll get up to 180. And on the top you see bupivacaine and lidocaine. And those mimic the dwell time of both drugs in the sodium channel. So bupivacaine, even at the very slowest heart rate, has a dwell time longer than the slowest, whatever cycle you want to measure, R to R. Lidocaine is in and out, even with the fastest heart rates, before it completes a full cycle. And this is what many believe leads to the torsades de pointe, like R on T phenomena. And this one image has helped me understand this, share it in a way that otherwise I can't. Well, let's turn now to Stanford. 1979, you can read the editorial suggesting, and here's the quote, bupivacaine may result in almost simultaneous seizure, cardiovascular collapse without anesthetic and hypoxia from typical clinical doses administered inadvertently intravascular. Now the red, that's still within the quotes. The true incidence of this phenomenon, if real, needs to be determined. People don't read that second red sentence. Now Jerry Prentice, a good friend of mine in Honolulu, was at the University of Washington. The editorial was written about a case report that he'd put in with a titocaine caudal. And it was after that that 3/4 bupivacaine and other things was withdrawn from OB practice and ultimately led to the test dose by Moore and Batra. And of course, this led to plaintiff's attorney growth and interest of these phenomena. But it really, bupivacaine, I think, has been painted with this brush. For those that haven't seen it, and this is actually a torsades de pointe in dogs when they were looking at some bupivacaine stuff. I have seen 2 cases where it looks an awful lot like this. It's that disorganized electrical activity that you hope you have a pump. Now you hope you can reach for the intralipid and let pharmacy allow it to be used in the building. You don't have to go to the ICUs and steal it. It's amazing what you can find out how things work already just on the walk over in the morning. Well, let's talk about acidosis. Dan Moore, Bob Crawford, James Scurlock, actually following all the focus on bupivacaine being so terrible, started getting blood gases on patients that had seizures. So they looked at a 25-year-old woman, 15-year-old male, during epidurals. And I'd ask you to look at the blood gases and mostly look at the purple, the pH. At 3 minutes or less, this was the pH in both of these patients at an institution that had great experience with local anesthetic systemic toxicity, always did these in an induction room, always had people around to help do the case. So this wasn't somebody going off on a corner, nobody to help them. My belief from having handled a fair number of these, I think the acidosis may be as much the killer in this and not getting that corrected as anything we do. And remember that because we're going to come back around. So if you look on an acid-base chart, local anesthetic systemic toxicity sits up there kind of with birth anoxia, up in that quadrant. It's kind of unto itself up there. There's been no time to adjust with renal adjustments. You see, if you look at kind of a classic old cellular respiration pattern, we're trying to make that ATP. As you look at this, you're trying to have that ATP be made. You're trying to have ATP be made, and yet, as you look at this, lactic acid's going up. You've blocked really the hemoglobin. You're not circulating very much. Your CO2 is going up. And what happens when you have acute metabolic acidosis with a seizure? Your cardiac contractility is going to go down, cardiac output's going to go down. You're going to have predisposition to ventricular dysrhythmias. You're going to get some hypotension. Your catecholamines aren't going to work as well. If you look at a beta-adrenergic receptor, this is normal pH, it's going to be deformed. The adrenergic receptor will be deformed. And now we have to get to what is the best treatment for recovery. Well, I'm going to offer you up something that may seem very old-fashioned. First off, you got to ventilate. I was telling Lindsay a little story about a friend of mine. We were talking about, somehow we got on to ophthalmologists this morning early on, and I remember my days in Seattle. We lived on a deep curve on Mercer Island. A young boy just graduated from high school rolled his car behind my home on a Saturday afternoon. My next door neighbor's an ophthalmologist, worked with me, very good friends. We both run out there. I actually had IV fluid at home and kits because when the kids got whiny about going to school, I'd plug a liter in and you could very quickly tell how sick they were, and it really pinked them up if you got a liter of fluid in. So I had some bags of fluid at home. So before EMS got there, I had 2 liters in this young accident victim. So Monday, ophthalmology friend and I are at the doctor's dining room, and he said, "Boy, Dave, I was sure glad you were there because I could remember ABC, but I couldn't remember what they stood for." And so as you resuscitate people, make sure probably it's not an ophthalmologist that's hanging around with you. But I say that, look at point 2, stop the seizure. This has caused a lot of confusion in the literature and in medical practice. One of the things I often do is I try to make sure I've got some succinylcholine somewhere around with an adult undergoing a major regional block so that if they do have it, I can shut off the CO2 factories, which is the muscles. And so that's often the first drug after oxygen that I give. Now, you have to make sure that one of the first drugs you give is intralipid. It appears to be a real life-saving maneuver. And then support the cardiovascular system. If you have a pump, there have been patients saved from a pump. It's rather dramatic. Most of the time you don't need to do that. But keep in mind, if you're out in an ASC somewhere and there's no cardiopulmonary bypass, then you better be better at intralipid. Well, let's go back to this oxygen as an antidote for systemic toxic reactions. This is two good friends, Dan Moore and Don Breidenbaugh. They really probably have more experience with seizures than anybody in the world. You can see that their seizure rate back in the 40s and 50s was at a 1.5% rate. They advocated oxygen and succinylcholine. Now, some of you know Dan Moore. Dan was never short of opinions. He knew always what to do and often didn't change his mind much when data presented themselves. But he was a very, very good anesthesiologist. Rudy DeJong, another Seattleite, Jim Heavner, who's now down at Lubbock, teamed up, published in JAMA. This was an experimental study, but talked about why benzodiazepines were so much an advantage in stopping seizures. They, as you can see on this vertical axis, percent convulsions, horizontal axis is the milligram per kilogram of IV lidocaine, and look how you can move the diazepam curve far to the right compared to the unprotected or non-administered group. So it's really the GABA A receptor that you're binding benzos and barbs to, and that's why it actually works. Then let's go to South America, to Argentina, and Usabiaga actually had a little bit of a tiff with Moore and Breidenbaugh. And the bottom line there is you see this experiment, and these were residents, young faculty, they actually seized them. They actually administered enough to seize them. And they proved that succinylcholine did not stop the EEG seizure. Well, this was a little bit of push at Dan and Don, and I still hear people getting confused about, that succinylcholine is going to expose the brain to a seizure, and you might burn the brain up. And best I can tell, I don't think there's a single episode where a seizure has actually burned the brain up, unless it's been, an ongoing seizure for years and years. Remember, the reason you might give succinylcholine or relaxant is to shut the CO2 factories off, so the acidosis issue isn't as big a deal. Chris Bernards, when he was one of our fellows at Virginia Mason, actually we did a study in pigs where we looked at diazepam and midazolam, and we were less able to resuscitate pigs if they'd had diazepam than if they'd had midazolam. So again, keeping in mind that one of the thoughts is, as somebody's acidotic and now we throw other cardiac depressants in on these folks, that we might actually be worsening the resuscitation. Then enter Guy Weinberg. Guy, many of you know his story. He was studying a particular patient and came across the concept that you might be able to isolate the bupivacaine inside intralipid in a way, have it sucked in like a big sponge. And he probably, if I think about somebody that's actually advanced regional anesthesia, a huge amount, it's Guy. If you look up Google lipid rescue, you can learn about as much as I know about this. But he's got quite a website. It's a little bit getting, I guess it peaked probably 2 years ago. But I think it's probably wise, if you're doing regional anesthetics, to have intralipids somewhere close at hand that you don't have to go storming around and and trying to get from the ICUs now. You have it on your cart somewhere. And that's why you may need another person around to help you give that. His original study in '98 showed really the mortality after a bolus of bupivacaine resuscitated with either saline or lipid. And you can see the saline in black circles and the lipid in the open circles. I'd offer up to you that this doesn't seem as dramatic to me as some of the case reports that are coming out. I think it actually is an advantage. This happens to be out of his ANA paper in 2008, showing what the hemodynamic responses are to local anesthetic systemic toxicity while you give intralipid. And the L2 mark is actually just the second infusion, and actually seeing how, in a sense, I visualize this as the bupivacaine just being sucked back in to that lipid interface, and the receptors actually working again. Meg Rosenblatt and the team talked about a case, first case published. You can see, not always straightforward. History of angina, had a cabbage, age 43, had a interscaling. Seizure was 30 seconds after the needle was removed, and they used intralipid. On the website, Guy and the team actually show you how to put things together, and it's really, you put that in there and you give most of it, is what you do. You give about 1.5 ml per kilo off the bat, and then you end up repeating it in 10 or 15 minutes. And there you can see it. You can run an infusion, and I think most of us, if one dose worked, you'd follow Ampule's law and you'd give whatever was left in 10 or 15 minutes. But this appears to be something that we should all know about. So if I close this, here's what I think we need to do. We actually need to understand this. We need to have people using intralipid when they can. Almost all the events are related to direct intravascular uptake. You have to be somewhere where you have others around to help you. Tomorrow evening with the medical students, I've only got a slide or two left, but after that, we're then going to go through a problem-based learning of a 16-year-old boy that's dead because somebody did a femoral nerve block in the corner of a recovery room to hurry things along, and it was fully 8 minutes before any cardiovascular acting drug was able to be administered to this young man. He's dead. Bupivacaine cardiovascular collapse in an ASC not very long ago. So we're still killing patients unnecessarily, partly on the basis of production pressure. Just like every patient we care for with a general anesthetic, when we push a relaxant, we've guaranteed we can maintain their airway. With local anesthetic, we've guaranteed that we can resuscitate them. And a major dose of local anesthetic is enough to cause harm for any one of us. And so I just ask you, remember, acidosis develops very rapidly. You may have to work on that as well as the cardiovascular support, and find a way to use the lipids in care. And with that, I'm done. Happy to take any questions that you might have. Larry?
David, does intralipid have a role in a seizure caused by an intravenous injection of lidocaine?
So the question is, if I had a seizure, I'd use lidocaine, would intralipid be appropriate? It probably would, but most of the time we won't have used enough lidocaine to make a major disaster out of it. But I would, if the seizure had actually gone on. Intralipid is nearly, in my opinion, devoid of serious complications. And I do it in part just like I do in aviation. If something bad happens, I use my usual stuff so that I get better at using my usual stuff. I think that'd be the real rationale, Larry.
So would you use it rather than using a sedative hypnotic, for example, to avoid
If I caused a seizure with lidocaine, most of the lidocaine seizures I'm familiar with, it's a fairly quick onset, fairly quick offset, and usually doesn't recur. So I'd probably just support their airway and go on and on. But if I had any issue with dysrhythmias, I'd probably just mostly as practice, get the intralipid drawn up and start it. But mainly, again, to make sure that our team is functioning so that for the next time when I'd use bupivacaine, it would work. I doubt that you'd have much problem with almost any dose of lidocaine we give. Yes?
I just want to make a comment on the OB situation where it is possible to get cumulative toxicity, although we think that with the very dilute solutions we use, it's not a possibility. Particularly if we're using multi-orifice catheters, we may have a situation where one of the holes, due to the flat situation you're talking about, negative aspiration, one of the holes is in a vessel, we're getting a partial block, we mess around with it, it's a long dysfunctional laser, pushes a lot of drug, we redose her every hour with something more concentrated, she gets a bit more comfortable, and ultimately she has a C-section, we give her a big dose of surgical, whatever, lidocaine, bupivacaine, or ropivacaine, so that this is a particular pitfall because people don't see it coming and they don't consider that this is a possibility. And a couple of things to think about is, as well as the intralipids, which I think should be something we should do, delivering the baby immediately will make the mother more resuscitatable and make her less liable when she survives to organ brain damage. And that thinking about, we don't use the test dose of lidocaine and epinephrine, but just thinking about what would you expect to see every time you give a drug, and if you're giving an amount of drug that could cause a seizure, then that's too much, and that might need some kind of additional marker, epinephrine dose, to tell you where you are or where you're
Good. Thank you.
You didn't touch about bupivacaine at all as far as toxicity is
Okay.
concerned. Number one, and number two, since the use of indwelling catheters for regional anesthesia for postoperative pain control, sending patients home, the message you're sending out here is, if you put a catheter in, even if it's intravascular, we don't really have to worry about it.
Well, if anybody interpreted that from my comments, I erred, because catheters cause more confusion than clarity very often. And I actually think, let me take the catheter issue first. If I can get by with a single injection and not have a catheter, I'd much prefer that. And the reason being is you own that catheter and you're responsible for that catheter. Actually, Hospital for Special Surgery and some of the larger centers on the East Coast are actually moving away from homegoing catheters right now for some of their work, mainly because of cost, but it also lowers the risk of responsibility if you've done a single injection and then put them on a protocol to actually move to oral drugs overnight. And I actually think some of our catheter work is a technologic imperative. We've designed it. It's actually kind of nice when you can stimulate the end of it and find it and move it around. But I think some of that is almost our techie side that's coming to bear, and I'm not sure we need it as often as we're doing it. I know we're going through that right now at the clinic. I'm pushing on the team to actually try to understand when we actually need to use catheters, partly because I'm not sure my budget's big enough to buy all the catheters we need. Ropivacaine, let's go to that. People are dying of ropivacaine across the country as well. I didn't talk about it today, but I want to just paint a word picture for you. This hand is bupivacaine toxicity. This hand is lidocaine toxicity, and the risk. Where's ropivacaine? It's by my right elbow, not somewhere in the middle. They're much more alike than unlike, and I actually wonder if it fits into Gerald Wild's theory of risk homeostasis, a Canadian psychologist. As we make something safer in one area, we express more risk so that we actually are expressing total risk stays the same. Ropivacaine is a little bit safer when you look at it in basic science. But because of that, I'm a little sloppy in how I give it. I may give a little larger dose than I would have of bupivacaine. I pay not quite as much attention. And so functionally, we've got the risk being expressed at nearly the same level. And I know of numbers of cases of ropivacaine deaths in the last few years. So a very, very good point. I probably was dating myself more than anything with talking mostly about bupivacaine, but you could almost express ropivacaine in the same vein. Sean?
Comment and then a question.
Yeah.
Very contemporary and topical talk, and particularly in light of the fact that we're using more and more intravenous sodium channel blockers to give systemic analgesia, particularly lidocaine, and finding that it's got great analgesic effect in the perioperative period, but at least as importantly is reducing opioid use. So we're seeing more and more use of this both intraoperatively and also perioperatively, and then the accumulated issue really comes to bear. I appreciate the decreased sensitivity with lidocaine, but clearly people need to be aware of this as we'll probably be using it more and more. Secondly, there is some recent research showing mutations in sodium channels that are leading to a susceptibility to seizures in NAV 1.1 and 1.2. And I guess my question to you is could these people who have a seizure after local anesthetic toxicity, which after an injection, which I've unfortunately seen firsthand myself, do we believe it's really a PK issue, or could it in fact be a PD issue?
Yeah, I think your question well articulated, and I don't have an answer. I think it's indeterminate. I consider myself primarily what I call a POA. That is a plain old anesthesiologist, and I wish I was smart enough to know what that answer is. I would guess I've got to give a lecture this fall at the ASA on genomics.
Sodium channel 1.1.
Well, that's very good, Sean. I'll email you and get some more of these data because I'm struggling. I'm supposed to give this kind of old man overview of genomics for an anesthesiologist, and holy smokes, I mean you could go on and on and on, and I'm not sure what I've said, but I bet we'll find people that are exquisitely sensitive, and we may in fact see some patients that are seizing that have a propensity to seize that's different than most of you sitting in this room. And this age of personalized medicine, I think one of the chaps is Edmonton, Alberta. He's a kind of an ethical, focus ethics and science. I think his name is Caulfield, a chap by the name of Caulfield. He has written, I think, some of the most telling things about genomics. And he's kind of a genomics and an ethicist. And he says he thinks we've actually hyped genomics a bit right now as the savior of medicine and all this, to a point that we're actually doing it a disservice. So I'm anxious to get more into his writings to see. They just had I think it was a Nature article earlier this year on that topic. So if you Google Caulfield, I think it's C-A-U-F, and then it's E-L-D or F-I-E-L-D, and very, very interesting reading. It's something I still remember the page in Nature. It says the bubbles, has the genomic bubble burst, I think is what the commentary is. But I think, Sean, very good. There's so much we don't know. I think we're going to look back on this in 50 years, for those that are still around, and say, how did we do that? How did we go so blindly? Okay. Yes?
If you say that the mechanism of bupivacaine is fast in, slow out, how is the mechanism of the intralipid? How does it work?
Well,
Intralipid is not going into the cellular.
best I think, intralipid, the question is, how does intralipid work? I think Guy Weinberg and the team would say intralipid is like an intravascular sponge that just sucks bupivacaine back into a very lipid-filled area. It's actually acting like an intralipid sponge. And that may be oversimplified. I think that's it. Yeah. Well, thank you all very, very much. Look forward to seeing some of you today.